Welcome to Variations 4, Gastrointestinal Unit. Looking at questions 11 and 12 here. Even though it says gastric ulcer here, it's actually peptic ulcers are the topic. So it's about peptic ulcers. So 11 should say, peptic ulcer treatment and prevention. What is the action of these meds? Also asks when should antacids be taken. Then it asks about some positives and negatives around anticholinergic drugs. Let's look at all those issues here in map. It's actually map 6 and beyond, as it says here. So we all know what ulcers are. Ulceration is basically a compromise of the mucosa. It could be of the intestine or of the stomach, and it causes bleeding, and it can cause perforation, and it can cause, as we talked about above, fibrotic tissue formation, et cetera, et cetera. The list goes on and on. But typically, when patients come to the hospital with ulcers per se, they've come in with a lot of blood loss, lightheadedness, pain in the gut, and we find that they're actively bleeding. And our main goal really is to decrease, well, for sure, give them blood transfusions if needed, and boluses and whatnot, for sure. But in terms of managing the peptic ulcer, what do we need to do to stop that ulcer from getting worse and to give it a chance to heal? What is it that we need to do? We need to decrease the hydrochloric acid secretion that's going on in the gut. That's the main thing we need to do. And so we have these histamine 2 receptor blocker meds, and really we don't need to know the whole formula here. The bottom line is it ends up with we end up with a decrease in the hydrochloric acid secretion, and the mucosa is able to heal. Same thing with our proton pump inhibitors like Pantalog. Okay, and then just a little side note here on antacids. Apparently, you should take them with food. They will stay in the gut longer, to coat the gut longer if they're with food, and to have their action for a longer period of time. If you take them on an empty stomach, they're actually evacuated from the gut pretty quickly, as you can see here, half an hour or so. Where if you take them with food, their effect will last longer. Okay, back to the topic of medication and ulcerations. Anticholinergic drugs can have the same effect as the proton pump inhibitors in that they end up causing a decrease in hydrochloric acid secretion. There are issues with anticholinergics, though, that you need to be aware of in general. In general. We'll come back to this right side of the diagram in a minute. First of all, just a little bit of discussion around anticholinergic drugs in general. And that is this. You're going to see the use of anticholinergic drugs in different areas. For example, we use it in palliative care quite a bit. You can see them used in the management of ulcerations, although I don't think it's the drug of choice. I think you're better off using like a proton pump inhibitor, like Pantalog. And you know what? If it's a real emergency, we'll give the Pantalog via IV anyways. Okay, but so back to the point at hand, though, anticholinergics are drugs. We do see quite a wide range of use of them in healthcare in general. What do they do? What do anticholinergic drugs do? At the end of the day, what they're doing is they're decreasing the effects of the parasympathetic system. They inhibit the action, the bodily actions of the parasympathetic system. By decreasing levels of acetylcholine, which is why they're called anticholinergics. Okay, but in layman's terms, what does it mean to decrease the effects of the parasympathetic system? Write a list of all the bodily functions that the parasympathetic system is responsible for. And I'll give you a hint. Any word, bodily function that ends in A-T-I-O-N, ation, is probably a product of the parasympathetic system. Try and write a list. Let's start from head to toe. The parasympathetic system causes the following bodily functions. Lacrimation, that's the formation of tears. Salivation, that's the production of saliva. Defecation, having bowel movements, that whole, everything around peristalsis, hydrochloric acid, anything around digestion, including defecation. Urination, so anything to do with the smooth muscles of the bladder, for example. Parasympathetic system is often, we say it's the rest and digest system, okay? So if an anticholinergic is decreasing the actions of the parasympathetic system, what are some of the unwanted side effects? Go through your list and list them. Dry eyes, dry mouth, constipation, urinary retention. The anticholinergics are supposed to decrease the production of hydrochloric acid, but on the other hand, because they decrease motility, they may allow acid to kind of sit around, if you know what I mean, and build up in that way. And so it's really a question mark as to how effective these are. Moving along to question number 12 is asking us to look at the head-to-toe diagram for the peptic ulcers, and let's see what we come up with. Someone has a peptic ulcer. I think a lot of these things are pretty self-explanatory. Why would you need an NG tube? Again, you have to ask yourself, why has he got the peptic ulcer? If it's from alcoholism, for example, well, maybe he won't need the NG tube. If the ulcer is from Crohn's or colitis, then he might actually have a bowel obstruction happening as well, and then thereby needs the NG tube. Why NPO? There it is right there. Decreased hydrochloric acid secretion. A little note about IV Pantaloc. A little sidetrack here. We know what Pantaloc does. We discussed it above. IV Pantaloc can be given either intermittently on a secondary IV line, and if you haven't covered that yet in INP4, you will, or it can be given continuously on a primary line. The exact indications for one or the other, we'll leave that to the physicians to work out, but generally speaking, my experience has been that when it's continuous, the patient's in a bit rougher shape. When it's intermittent, the bleeding's not as bad, and they can have a few hours between each secondary IV, and it's obviously not as bad of a case. That's been my understanding of what I've seen out in practice. By the way, IV Pantaloc is not a medication that you are currently is in your scope to give, but yet some of your patients may be getting it in collaboration with the other nurses. So you need to know a little bit about what to look out for in terms of managing this med. I want to talk more generally. Meds that are continuous, let me rephrase that. There are some meds that are continuous that should never be interrupted. There's like a hot list of meds that you should never interrupt and do everything in your power to keep them running. and it would be very urgent if they were to stop running. A continuous Pantaloc infusion implies that the patient has got a serious bleed and that, or serious ulceration, and that if we stop that continuous Pantaloc or interrupt it, that bleed could get worse quickly. So we would not run a continuous infusion of Pantaloc on a secondary line. Why? Because if the bag ran out on a secondary line, you wouldn't know it because you'd just flip over to the primary line. If a primary line runs out and you're on a pump, the pump will start to beep and won't stop beeping until someone takes care of it. If what I'm saying now is in any way unclear, leave it for INP4. We'll have more hands-on or at least more videos around this for INP4. So leave that for now. But there's a list of meds you never want to interrupt that should always be run as primaries. Pantaloc's one, insulin is another, heparin is another. If some ulceration is bad enough, they might get a partial gastrectomy, and that's the removal of part of the stomach. And then it's anastomosed to a part of the small intestine, and it's business as usual, so to speak. But while they're healing, they will need an NG tube, because as the stomach that's being resectioned is healing, you don't want any pressure of gas, fluids, or contents against the wall that's healing. So there'll be NPO, and they will have a continuous NG in removing gas and fluids. That NG should never be stopped, because you do not want that stomach to fill up and press against the surgical lining. Dumping syndrome is before the stomach is able to get back to kind of working a little more normally. It will allow large amounts of fluid to flow directly into the small intestine. So you can lose a lot of the nutrients you should be getting. This is generally a risk of resectioning a stomach, is that basically you get this direct flowing of fluids, your plasma, which is your water portion, and your nutrients just kind of fly right through the intestine, and you can be at risk for dehydration and nutrient loss. This is just a complication you want to look out for when you have a partial gastrectomy.